Thinking about treatment approaches to pancreas cancer, so starting with resectable patients, that's about 10 to 15% of all patients who are diagnosed with this disease are potential candidates for surgery. For those that have a clearly resectable tumor, and that's defined by no evidence of metastasis and no evidence of major vascular and in particular arterial involvement, such as no SMA, no celiac axis, no common hepatic artery involvement. For those patients, there are two approaches. The conventional approach would be upfront surgery, followed by adjuvant therapy. An alternative approach, and practiced by some, mostly academic centers, would be neoadjuvant therapy and then proceeding to surgery. Adjuvant therapy for pancreas cancer has been an area that's been in flux, but it's clearly been shown to improve outcomes for patients who undergo surgery in terms of delaying tumor recurrence and enhancing overall survival compared to observation. And right now, gemcitabine as a single agent remains a standard of care. An alternative is 6 months of fluoropyrimidine-based therapy. Controversial consideration is where adjuvant chemoradiation fits and whether that should be included routinely. And in fact, the current national study supported by the NCI is evaluating the role of radiation in the adjuvant setting. That's RTOG 0848, which has been open for about 5 years now, and initially was a randomization to evaluate erlotinib combined with gemcitabine in the adjuvant setting. That subsequently has been discontinued. And now, after 5 months of single-agent gemcitabine, patients will get randomized to the inclusion of radiation or not. So this is an important study. It has struggled because of concerns about whether we should be routinely recommending radiation, but in truth, this is the only way we'll answer that question for the future. So that's a quick synopsis of what's happening in the adjuvant setting. The other point to make is that the value of a second agent in the adjuvant setting has not been validated as yet, and there are a series of ongoing randomized studies. So for example, in the UK, the SPAC4 trial has recently completed recruitment, and that's evaluating the addition of capecitabine to gemcitabine in the adjuvant setting. So those data hopefully will be forthcoming in the next probably 2 years. In North America, now a global study, a trial called the APACT trial is evaluating the addition of nab-paclitaxel to gemcitabine in the adjuvant setting, a very logical follow-on to the use of that combination in metastatic disease. And our European colleagues are evaluating FOLFIRINOX in the adjuvant setting. And so probably in around 5 to 6 years from now, it's likely that the current standards will change based on the results of these and a couple of other studies.